handling the situations. Very good. Now the last topic coming up, not the least, I think the most important topic, because normally I don't get time for my multifocals or premium IOLs to evaluate how they are doing well. We just do get 6x and 6, fine, just the patient go. So we are going to hear from Madam the evaluation, post-operative evaluation of premium IOLs.
Not this. Which one? Ah. Only one. Okay. A very good afternoon to everyone. My topic is premium IOL post-operative evaluation. There's no conflict of interest. Now, premium cataract surgery has tripled over the years and patient demands have become more challenging. Premium cataract surgery requires safe cataract surgery without significant post-operative complications. And IOLs should provide a predictive and excellent post-operative result. Now, comparing to conventional IOLs, premium IOLs offer more and better visual function. There are no standard criteria because of continuous evolution of IOL technology. The aspherical IOL, blue light filter, square edge IOL were described as premium IOLs of the past decade. The rapid shift to digital platform has brought about a lot of changes in the demands of the patient, and the patient demands clear vision at all distances. Now, how can we address this shift in the patient's demand? The present day premium IOLs have already been described. They are like the monofocals, like the Clarion IOL with the automated injector system, extended depth of focus IOLs. Then you have the multifocals, and then you have the toric monofocals and the multifocal IOLs. Now, patient criteria has already been dealt with. Now, what has been promised pre-op? The patient has been, the quality of vision is of primary importance for premium IOLs. Spectacle independence for distance, intermediate and near for multifocal IOLs. Presence of minimal photopic phenomena, glare, halos, and dysphotopsia. A good contrast sensitivity for multifocal IOLs, and social vision in case of EDOF IOLs, and an overall patient satisfaction. The post-operative evaluation involves the visual acuity for at all distances, contrast sensitivity, slit lamp evaluation for corneal clarity, iritis, anterior chamber depth, IOL centration, and posterior capsular opacification. The quality of vision is assessed by subjective and objective methods. Subjective methods can be by a questionnaire, like we can ask the patient, are you satisfied with surgery? How often do you need spectacles? And whether he would recommend this surgery to others. And what is the frequency of halos, diplopia, and dysphotopsia. Objective measurements include specular microscopy, corneal topography, tear film abnormalities, aberrometry, then higher order aberrations can be measured. And there are halometry devices which can measure the impact of halos. It has been said that 40% halos are there detected with multifocal IOLs, but actually 10% may be of significance. Then devices which measure the quality of light diffusion inside the eye, and then there are devices which measure contrast sensitivity. So various devices are available for an objective measurement. Now I'll highlight some of our experiences with premium IOLs. Starting with the Synergy multifocal IOL, we had done 50 eyes this year of 27 patients, out of which 46 eyes had bilateral surgery. And we found that 90% of the patient had uncorrected distant visual acuity of 6.9 to 6.6, and 92% had a visual acuity for unaided near vision acuity of N6, and 8% had visual acuity of N8. You can see the well-centered multifocal IOLs. Then the IHANS EDOF IOL, we found that 96% had uncorrected distant visual acuity out of the total of 213 eyes. And most of them required near vision correction. Intermediate vision was good in all the cases. Now coming to the EDOF Vivity IOL, we had done 33, total number of 33 eyes, out of which uh, s- uh, so we had some bilateral cases also, and the 11 eyes did not require additional near vision correction, but most of them needed, out of these, most of them were the patients who had done bilateral surgery. And most of them required a near addition from starting from 0.75 diopter to say plus 2 diopters. Now, out of the toric multifocal IOLs, post-operative evaluation, the anatomical outcomes depend on the type of the marking method, IOL material design, rhexis size, and centration. And the functional outcomes, it has been, studies have found that 20/40 unaided vision is achieved in 70 to 100%, and uncorrected near vision is achieved in 100%. Spectacle independence is 79% to 100%, with a lower degree of residual astigmatism. In this, our experience is still limited. We implanted toric EDOF VVT IOLs in 15 eyes. 6 were bilateral and 3 were uniocular. And 2 eyes of one patient, we had done a panoptic toric IOL. The uncorrected distant vision at 1 month was 6/9 to 6/6 in 14 eyes. And now coming to the EDOF VVT toric IOLs, uncorrected intermediate vision range from N8 to N12 and near vision from N8 to N10, and the ad was ranging again from plus 0.75 to plus 2 diopters. There was no unhappy patient. Now this shows the picture of a VVT toric and a toric IOL. And this is a toric panoptic with the post-operative slit lamp photo of a well-centered IOL. In 2016, we had done a study on multifocal IOLs, a comparative study between the Acry-Lisa 116 eyes and IDIF IOL from the CARE group, 80 eyes, and we found that the spectacle independence, unaided visual acuity of 6/9 or better, and near vision of N8 or better at 3 months post-op was 87% with the Acry-Lisa, with 97% for near, and 80% spectacle independence was found in the IDIF group. Contrast sensitivity and incidence of PCO was similar in both the groups. Now I'll present a difficult situation where a patient with a PPC wanted a multifocal IOL. One eye was operated with a multifocal successfully, and he was a happy patient. At the time of the second eye surgery, video starting. The nucleus was being emulsified, and that time I noticed a PC rent. So I stopped and did an anterior vitrectomy and removed the cortex, and finally I could implant the IOL in the bag. It was my good luck that I could do it successfully. And this was the post-op pictures of both the eyes. They look similar on slit lamp. And you can see the dilated photograph where you can see the PC rent and the IOL in the bag. Post-operatively, the patient did well. He had some macular edema, cystoid macular edema, with and he complained of floaters because some lens matter had fallen into the vitreous. But eventually, the condition resolved and he was okay. Now, with premium IOLs, the post-operative chair time is important because premium IOL patients require more chair time, and the studies have found that patients bilaterally implanted with premium IOLs, they require more chair time of say 5.5 hours per year, and they require more diagnostic testing, and they require more YAG procedures. To conclude, good pre-operative history and evaluation is very important to have an excellent post-op result. Surgeons should determine pre-op which IOL is best suited for a particular person. If the surgeon has blundered pre-op, nothing can be salvaged post-op, and look for overall satisfaction. Thank you. I thank the KSOS for giving me this opportunity today.
Thank you, ma'am, for the wonderful